I tell patients there's 5 reasons why your nasal resistance and flow could be suboptimal. Number 1, you're just massively inflamed. Your nose is just full of allergy, the turbinates are just hypertrophied. You're like stuffed like a Thanksgiving turkey. Number 2, you have an anatomic abnormality beyond inflammation, like a deviation, or some type of anatomic problem in the nose that's blocking, like nasal valve collapse, things like that. Number 3, the entire bone is too small, as you're well aware, Ron, the transverse maxillary deficiency. Number 4, if you're severely retrognathic and you have a very small pharyngeal airway in the back, you will have less flow through the nose, right? Because you're impacted back here. But I always tell patients, hey, the 5th reason is that you may be weak. You may just have weak respiratory muscles. And so look at this woman here now to the right, just based on some of the numbers came to 0 because I didn't have it set at the correct numbers. But the point is the numbers that came through, you can see that the 57 went to 178, triple. She basically over tripled her flow just based on training her lung muscles, nothing else. She did not do CPAP or BiPAP, surgery, allergy treatments, nothing. The only thing she did was EMST and IMST training. That's it.
Jenny, so
Yes.
What's your role with Dr. Rama?
So Dr. Rama and I met a few months ago. I actually work with Aspire Respiratory Products, the makers of the EMST devices and the adapter. And Dr. Rama reached out to us and we talked a little bit about the research behind it and sleep apnea, went over how to use it. And he did a great write-up on his website, and I'm super excited to hear about his experience with it with his patients.
Fantastic. Okay, so you represent the maker of these devices.
Yes.
Okay, great. Awesome. So what's the objective of the meeting today? What did you guys have in mind in terms of what you wanted to accomplish? I know part of it was to sort of get me set up with a protocol that I could enact over the next several months, and then we were going to do another sleep study to see how using these tools affected my sleep. Is that right?
I think the goal was, number 1, to introduce your audience to maybe a flavor of some non-surgical treatments for sleep apnea, number 1, because everyone's so focused on expansion and advancement and all these surgical nuances. I thought, hey, maybe it's nice to broaden your channel a little bit and have some surgical options. And number 2, I thought it'd be interesting because everyone knows Ron, everyone knows you so well on your channel, obviously, right? I thought, hey, you'd be a great case report. And whether it works or not, who knows? But it's real time to have you do a watch pat, do 8 to 12 weeks of training and repeat the watch pat, see how you feel subjectively, see what the data shows. And I think the audience will learn so much along the way.
That sounds good to me because, number 1, I'm interested in not only bringing great content to the audience, but also to improving my sleep. And so this is an experiment that I certainly want to run for myself prior to, as you know, I'm planning on doing a jaw surgery. But like so many people, I don't want to be one of those people who, even if I do a jaw surgery and I don't get the improvement that I've been looking for, maybe, as you suggest, the answer was somewhere that wasn't in the skeleton or in the the jaw structure itself, but maybe some other thing that like muscle tone or muscle strength that could be improved with some of these devices that we're going to talk about today.
Yeah, and I will just say, I think that most people, if there's an option to go non-invasive, you often want to try that first, or use it as a complementary therapy if it is something that helps additionally to what they do.
Yes, a lot of my audience, I think, thinks that they've tried a lot of the alternatives to surgery, and so a lot of them come to my channel because they've been Googling surgery. That's how a lot of people find my channel. That being said, there are things that I don't think people realize are available to try. Maybe they've tried other modalities like CPAP. For example, a lot of people who come to my channel are giving up on CPAP, and so they want to take the next step. But I don't think they've considered things like capnotherapy, which is another thing Dr. Rama is big on, into this. So why don't we dive right into these? Mine are not yet assembled. Do you guys have models that are assembled? And maybe we could just begin with an explanation of what these are and what the idea is behind them.
Definitely. And I'll say this was developed not with the idea of being a tool that would be used in the sleep apnea space, but in recent years, the research has really become a lot more robust in support of this, and the results are quite positive. So I think we're still learning a lot about it, but from what we know, it has been helpful. And it's super easy to use. Like we said, it's non-invasive, it's relatively low risk, and it's accessible to just about everybody, right?
Great. So Jenny, could you introduce yourself and explain your role and then maybe dive into the background of these units?
Yeah, my name is Jenny Opalinski. I am by training a medical speech therapist, though I have been in healthcare for over a decade. The population I work with clinically is mostly trach and vent, which is why I'm so familiar with these devices, because we use it there. But about 4 years ago, I started working with Aspire Respiratory Products, and I work with their education outreach department. And I have been spending my time reading our respiratory muscle strength training research daily for the last 4 years. So this is a really exciting thing that came about that we didn't even really expect, and a great application of the tool. So I can lead you through it. It's very simple to use. In the box that you have, Ron, you'll see the device.
So I have two devices.
Yeah. So we'll start with the IMST 150. So you have the Expiratory Muscle Strength Trainer, which is the IMST 150. And in the other box, you have the adapter. So correct. So in the box, and people may sometimes be confused by this, there are two mouthpieces in there, a blue round one, and then the white one. So
maybe just slow down just a little bit, Jenny, so he can demonstrate to the audience.
Two mouthpieces, a white one and a blue one.
A white one and a blue one, and then you have nose clips. For many people, the nose clips may not be necessary. The nose clips are used for people who have a difficult time stopping the air from escaping through their nose when they're training.
Okay.
So you can trial it. If you need them, they are there, but a lot of people do fine without them.
Okay.
Okay. So in terms of mouthpieces, you would choose whichever one is more comfortable for you. And what you want to kind of pay attention to is that there's no air escaping around the mouthpiece. So you have a really good lip seal. A lot of people prefer the white one. Yeah. And assembly is very simple. All you do is put the mouthpiece into the device.
Okay.
And then you're ready. Easy. Okay. So then for training, the general protocol that we recommend is doing 5 sets of 5 reps, 5 times a week. So 5 out of the 7 days of the week. Any 2 days you take off, you can take off. It doesn't matter. Research supports this protocol, but I will say that it is not for everyone and can be adapted, right? So some people may have a difficult time doing this, and they can certainly adapt it to what they are capable of. Mm-hmm. In order to increase the pressure on this device, you just turn the knob, right? So before we do that, I'll just explain a little bit how these devices work, because if you Google respiratory muscle trainers, you're going to find a whole lot of them available on the internet, and there are devices that work in different ways. So this device is a pressure threshold device. If you look at your device, Ron, there's a valve and then there's a spring. So it's a spring-loaded valve, right? And as you turn the top of the device, it increases the tension in the spring, and therefore increases the pressure that you'll be working against. Mm-hmm. Okay, so there are other trainers that are resistive training devices where the way that they work is you have little holes in the device and the holes get smaller. So you would imagine breathing through different sized straws. As the straws got smaller, the resistance would increase, and it would feel different. But those devices can be airflow dependent. So you also think about, like, even if you're blowing through a small straw, you can work really, really hard and then you could work not that hard and you could still complete the rep. With the pressure threshold devices, you would be setting a pressure that you're working against, so your work is consistent and you know when you are improving or making progress or increasing your load, right? So if you think about all the things that you know about muscle strength training, those are things that are pretty applicable and important.
Yeah, as you get stronger, you increase resistance.
Yeah, and if you go to the gym and you're lifting weights, you're not going to lift like a 10-pound weight, an 8-pound weight, a 5-pound weight, right? You're going to just do your reps with the one steady weight.
Mm-hmm.
What I like about this product, Ron, is that it's very specific. Like the 150 stands for 150 centimeters of water of pressure. It's the same units that a CPAP unit uses. Also, the other devices on the market, and I have no connection to this company other than just using their product, but the other devices, you can't titrate a specific number. Like here, you can titrate 30 centimeters of water of pressure, 40, 50, 80, 100. It's very specific. So when we compare it to normative data, and we'll talk about that later, hey, we know where we're going and what our target is. Anyway, just wanted to add that bit.
Yeah, in other words, it's suited to being used as part of a scientific study to determine how it affects someone's breath strength and therefore potentially how it could impact their sleep, because it can be so carefully titrated and measured.
And that's exactly it. Like if you look at a lot of the research in support of respiratory muscle strength training, the devices they're using are pressure threshold devices for that reason, because you can have an exact number and they're calibrated, so we know where we're working.
Mm-hmm. Mm-hmm.
And just one more thing from a clinical perspective. Ideally, like in our office, we actually calculate a MIP and a MEP, and we'll talk about that later, and we can determine what it is based on, the American Thoracic Society guidelines and whatnot. But the reality is with this device, you can self-determine it in a crude way. And so it's fine. It allows you to do more on your own without having to see a doctor and get these other fancy measurements.
Do you want to break that down a little bit more in layman's terms? Just like practically speaking, what does that mean?
Well, I mean, what this does is what respiratory muscle strength training is you're trying to improve your maximum expiratory pressure, your maximal force, and you're trying to improve your maximal inspiratory pressure. But first, we need to know what the normative data is, and then once we know that, then we need to know what you are. And so, typically in the office, we have you. If you give me 1 second, I'll show you the device.
Sure.
And I'll just add, for what Dr. Rama was saying, you can use the device to kind of determine a baseline of where you are. Even if it's not a specific MEP or a MIP measurement, it's quite close.
What are MEP and MIP measurements? Are those the baseline numbers?
Those are the maximal either expiratory pressures or maximal inspiratory pressures. So how much force you have when you exhale or inhale, the maximum.
All in centimeters of water of pressure. So this is the Vitalograph product we use. It's just something like this, and there's a mouthpiece on it, and you put it on, it's connected to a computer and some other software, and then you blow as hard as you can, and you do that 3 times, and then the values have to be within 20% of each other. And then you take the highest number. You give the person the benefit of the doubt and give them the highest number. And then the same thing. You suck as hard as you can for 3 attempts. And if they're within 20% of each other, you take the maximum negative pressure, and that's your maximum inspiratory pressure, so to speak, right? And that's how you determine it.
And is that the number that we're following throughout someone's training, is we're trying to see if we're increasing their max over time?
You 100% will be increasing your max in inspiratory and expiratory strength.
But that's like the key benchmark in this whole conversation is max inspiratory and expiratory strength.
Very simple. There's also like sniff pressure. There's all sorts of other ones, but we're going to keep it simple.
Well, to use an analogy, like in weight training, sometimes people measure how many reps of 235 can you bench press? Can you do 10 reps, 15 reps, 25 reps? But when it comes to this, we're not interested in like how many reps of some mediocre number you can do. We're interested in what's your max.
Exactly.
Okay, understood. Even though when you're sleeping, well, is the max actually relevant to like sleeping? because presumably when you're having an impingement to your breathing, you need max strength to overcome that. And so help me work out why we use max.
This might be a good entryway, Jenny, for you to show some slides, some basic background slides on RMST.
Sure. Let me just make sure that I am able.
And Ron, I sent you some slides by email. And later on, we can pull them up if you have it.
Yeah, you sent me some stuff, and I definitely glazed over it.
Yeah. Okay.
All right, so let's glaze over this. This first slide is the respiratory system, right? So a lot of times we think of breathing, we think of the lungs, but there's a lot more involvement here. And in terms of sleep apnea, you see like the upper airway is very involved too, right? Now, when you're talking about inspiratory muscle strength training versus expiratory muscle strength training, you're focusing a little bit on different muscle groups. Although in general, the research shows whether you're training one or the other, you'll probably see some benefit because these muscles all work together, right? So for inspiratory strength training, you're targeting the diaphragm directly, and that is your main muscle of breathing, as well as the external intercostals, which are the muscles between your ribs. And then for expiratory muscle strength training, and if you did like when you expire, it's usually a little more passive. So if you cough, though, you're going to feel the contraction a little bit more. You're going to feel it in your abdominals and then the internal intercostals, which are between your ribs as well, and the submental muscle group. So the submental muscle group is right here, and that is more involved in the upper airway. And the reason we say submental muscle group, it's a group of muscles, but the studies are done using surface electromyography. So they don't pinpoint an exact muscle, but they do show activation in the muscles that are here. So this is a therapy that's often used for swallowing disorders as well, because those muscles are working for swallow. Right? But when you're toning those muscles, they're also involved in keeping your airway open.
And can you go back, Jenny? Just want to add one thing. And I know this is lower respiratory, it's respiratory muscle strength, but there's also oral muscle strength, and that's what myofunctional therapy works on. But this also works to some degree on oral muscle strength. It works on the orbicularis oris. When you have to wrap your lips around that white adapter and press hard, it's strengthening your lip muscles. It's strengthening your tongue to some degree. It's strengthening your vocal abductors and adductors too. So it's doing more than just the respiratory muscles. It is working to a lesser extent on the oral muscles as well.
While we're on the subject of anatomy, an immediate contention someone might have with something like this is, well, you know, we're breathing through our mouth when we use this, but myofunctional therapy teaches us to be nasal breathers. Are there certain muscles that are involved in nasal breathing that are not involved in mouth breathing that get left behind when you use a tool like this?
I've never heard that question.
Sorry.
but I can assure you, when you do this, Ron, there's no way you'll be able to do this through your nose. I mean, it is incredibly difficult.
I do think it's a good question. And I think, though, because you're involving the diaphragm and these other muscles that are used in breathing, right? Those are the muscles that are forcing air too. Right, so that will have some effect on airflow, perhaps.
Yeah, certainly. I would think that there's probably at least like a 90 to 99% overlap between the muscles involved in nasal breathing versus mouth breathing, from here down. And maybe it's 100%, and maybe nasal breathing versus mouth breathing is just kind of like a neurological decision rather than like a muscular thing. I don't know.
Well, I don't know if there's any muscles in the nose. I'm trying to go back to my anatomy right now. So I can't think of one off the bat, but I could be incorrect.
I can't either. So I'll second that. But I think it's like I was saying, it's these other muscles that are forcing the air, right? So they are the muscles in the upper airway and the rest of the respiratory system.
But Ron, I had the same concerns. Hey, we're promoting mouth breathing, but it's really just for the training part. Then we resume back to nasal breathing.
Yeah, 5 sets of 5 reps.
So it's 25 breaths. That's excusable.
I think so.
Yeah. So, well, this is the training protocol that we talked about. So like we said, 5 days per week, you could choose your days off, 5 sets of 5 breaths. So 25 breaths a day. It's really relatively quick. Like you could do it while you're watching TV. And about 75% of max pressure. So here are just some simple instructions to finding your baseline training pressure. As we talked about, I don't know if you'd like to do that now or you want to.
Can we just back up, Jenny, just one thing? At least for my page. No, same page. I just want to comment so for my patients, Ron, I've just been doing it 5 days, but I've been doing it at their max pressure and not the 75% pressure. And on day 6, I just rotated a quarter turn. We'll talk about how it works out later, but I increase the intensity every 5 days and until they get to their target number according to their age and gender.
In the normative data?
Yes, exactly. And then I have them continue it for whatever we decide to do for you.
And why do you use the 100% of max rather than the 75%?
I want to make sure it works. So, I mean, sleep apnea is not easy to treat. So we want to,
You want to make sure that you're pushing the muscles as hard as you can and that you're not in some lower resistance level that's not actually strengthening anything.
Exactly.
Okay, got it.
And I don't know if the protocol was done for sleep apnea versus just, other reasons, right?
Right. So this protocol was developed and the research that it was used in wasn't specific to sleep apnea, although there are studies that do use this protocol that show success in sleep apnea patients. However, there are other studies that use different protocols. There's one that uses, for example, compares 30% versus 60%. And those are different numbers completely. They still show improvement, but the improvement was better in the higher intensity group. So again, like we said, some people may not be able to even do 5 sets of 5 reps at their 75%. It might be too much for them.
Got it.
But the protocol, this is a general protocol that can be adapted as tolerated.
Fantastic. All right.
Okay.
Did we want to try getting me going on this?
You know what? Let me go through the research a little bit, and then I promise
Ron is raring to go.
A lot of slides, and then we're going to get you set up.
Ron's ready to blow and suck right now.
I love the enthusiasm. For IMST, which is Inspiratory Muscle Strength Training, which is what you'll do with the adapters that you have, and you're targeting, like we said, the diaphragm and then some of the intercostals. The studies have shown improved daytime sleepiness and then improved sleep quality and improved inspiratory muscle strength, which we expect, right? And then here are some of the studies. I don't know if you want to share this, but we can just pause here.
And just for your audience, on my website, in the facts section under respiratory muscle training, I put all these articles down with a link to the articles.
All of these articles pertain to sleep disordered breathing?
Yes, and inspiratory muscle strength training. So, when I started a few years ago, it was like one or two couple articles. And so people were very skeptical, obviously, which they should be. But now this is just inspiratory muscle strength training. And then for expiratory muscle strength training, we saw improvements in AHI, improved sleep quality, reduced fatigue, reduced systemic inflammation and oxidative stress, which was interesting. And then, of course, improved expiratory muscle strength. Right? So these are studies done with specifically our IMST device.
So the takeaway, Ron, and for the audience, is that expiratory muscle strength training improves AHI. So when and up to 40% in some of the articles, correct, Jenny? Or
yeah, it was between 24 to 51%, if I'm remembering correctly.
Yeah,
which is pretty significant.
Yeah, and inspiratory is not necessarily improving AHI; it improves sleep quality and daytime sleepiness.
Right.
So it's a little fundamental difference. And I know your mind is churning right now.
Yeah, definitely don't understand sleep well enough to be able to like parse that out, but it's interesting that there's inspiratory and expiratory differ in that way.
And so, and just that we can just another comment. So if from my mind, the question I have is, do you do expiratory training first, which is what I had been doing, and then do you do inspiratory training after that? But then when I spoke to Jenny, she said, no, you should do both at the same time. And so that was,
Yeah. And I think we are all still learning, right? So like the research is more robust, but it is still limited. And anytime you read a research article, it's going to give you the limitations because there are always limitations, right? So it hasn't been studied in combination, but if we're seeing benefits here and here, then perhaps using both, if the person can tolerate it, might lead to even better improvements.
Mm-hmm. I mean, can we really say, though, that there's been sufficient work done to conclude that inspiratory training does not affect AHI at all? Or was that just like one thing that one study that was done?
Yeah, I think the work is limited. Like I said, I think we're still learning.
So it could be that at some point there's enough work done on this that we realize that inspiratory and expiratory muscles are equally determinant of sleep quality.
Perhaps.
Yeah. I think there's a lot more to it too, because there's other things like the capnography and hypocapnia. Mm-hmm. I don't know how this all works together, and I'm still learning too. But normal respiration in general is 1 part inspiration, 2 parts expiration. So that expiration has to really complete. But what I find with a lot of patients with sleep disorder breathing and small airways is that they cut off that expiration. So maybe they're 1 part inspiration, 1 part expiration. And so what happens is they drive their CO2 levels lower, and maybe part of the strengthening just allows you to finish that expiration. I mean, it's hard to know. Still learning.
Mm-hmm. No doubt.
But this will be an interesting case study for us, Ron, when you do both.
Yeah, you are part of the research base.
You're part of the science.
Finally, some real science on JawHacks instead of bro science.
Listen, bro science has a place too, right?
Clearly it does. Here I am.
Well, we're grateful to be here too. So if you'd like, I'll show you how to use the device.
Okay. Device in hand, and it's set to the minimum resistance right now. It's all the way down in green.
Yes, and I suggested having a Sharpie handy because a lot of people have found this little hack to be useful.
Okay.
Because as Dr. Rama mentioned, oftentimes when you're increasing or decreasing the pressure, we go by quarter turns, and you'll see like 4 little pillars on your device.
4 little pillars.
Like right here, right? 1, 2, 3. Sorry, maybe not pillars was the wrong word. 4 spaces.
On this top part?
On the actual device. So if you number them, it makes it a lot easier. So I'll show you how I'm doing mine.
Okay. That's what I thought. Okay.
Can you see? Yeah. So.
You might get it right next to the camera.
Well, I hope the audience,
Well,
so
maybe Ron can make the screen bigger for the people. In this way, the slide is removed.
Ron, you can show them.
You
can show them your numbers or my numbers. That's fine.
Okay, Jenny, go ahead.
That's much better. That's huge.
Yeah, 1, 2. I'm doing it the wrong way. 2, 3, and 4. So when you turn the knob of the device, you can have an easier time setting it to your numbers. And then if you take your Sharpie and just make a line where the silver screw is, that's your indicator.
Mm-hmm.
And a lot of times people find that little screw hard to see. But if you make a line there, that'll show you how far you're turning.
Okay.
Right?
And we're turning the line from 1
to
2 to 3 to 4. Quarter turn at a time.
So if you hold the device towards you, you see little arrows. You're going to turn away from the arrows to increase the pressure.
Right. You're following the arrows to increase. No, you're going against the arrow tip to increase the pressure.
Depending how you're holding the device. But if you're holding the device like this, looking at it, you're going against the arrows.
Got it. Okay.
Okay. So when you're starting at your baseline here, at your lowest point, you're at about 30 centimeters of water pressure.
Okay. Yep. And so that's the starting point of the
That's the
device.
starting point. And I'll just show you how to use the device. It's very simple, but just so that you have an idea of how it works. Your biofeedback is going to be this whoosh sound. You're going to take a deep breath. You want to sit up straight. You want to not puff out your cheeks when you blow in. And you want to direct all the air in and make sure no air is escaping around the mouthpiece and not escaping through your nose.
Okay.
A deep breath. And it's a forceful exhale. Did you hear the whoosh?
I did.
Yeah. My patients love the whoosh. And that's it.
She's yeah.
Yeah, you're a pro.
Yeah.
Not my first time.
Now, Jenny, quick question. Is there, like, sometimes patients ask me this, and is there a duration of the whoosh? I actually ask them to say, hey, at least 1 full second, because some people do this super abbreviated staccato whoosh, and I want kind of a longer whoosh showing that they've,
So I'm going to tell you, in general, we have said just do 1 forceful exhalation, and you don't have to sustain it. Not like some people are used to an incentive spirometer and they're trying to hold it. There is some research that just came out from Avery Dakin, and she looked at the difference in perception, in person perception of effort when they sustain the whoosh. So I think it's something that we're going to learn about more, but for our purposes, you just need 1 forceful exhale.
Well, to me, it sounds like a slight difference between strength and endurance. Like sometimes we test tongue strength versus endurance, your ability to hold it. So for me, I would think that the endurance also is
and I think
relevant.
That's exactly it, right? So perhaps that's something else that we can investigate with Ron.
I would do it long, Ron. 1 second, 1,000. Like I would do a long one for your trial.
So, okay. So I'm really raring to go here.
Let's get here, Ron.
All right.
Okay.
So, yeah, go ahead. Amazing. So, but you don't want to go too fast, right? Because you have some patients who are like, no problem. There's no reason to go fast. And you don't have to hold it like super long, right? So, and then I think take the device out of your mouth for a second so that you can breathe, and then do another one.
Can you try a longer one, Ron? There you go. So different.
It is different.
And I'll just say one thing, just when I'm testing patients, there's a huge variability in patients. I have patients that work out 6 times a week and they're weak. So it's not necessarily how much you exercise or whatnot. Some people just have weak muscles and some have stronger muscles. So like everything else, when you treat sleep apnea, you test and you try to find a deficit and then you want to target it. So we have no idea if you're weak or not, but definitely the people that are watching, some of them are very weak.
I mean, but there's professional athletes who are like doing respiratory muscle strength training, and you assume that they're strong, but it still is helpful to them. Not in terms of sleep apnea, but in terms of endurance and things like that. Right. So it is very different for everybody, but I think what you did is fine. So you would do a set of 5. Okay. That's my set of 5. And then you take a break. Okay. And you can do a full inhale and exhale in between too, so you don't get lightheaded, right?
Yeah.
I'm getting
it's interesting. It's interesting just for your audience and my patients that are hypocapnic, because we measure CO2 levels on everyone. My patients that are baseline hypocapnic, their CO2 levels are below 35 millimeter. When they do this, they're more apt to get lightheaded. So this might also be an indirect test for whether or not you might be hypocapnic. If you do get lightheaded, maybe you're baseline hypocapnic to begin with.
And my recommendation would be, please don't do it so quickly that you get lightheaded. Take a breath in between. It's okay. It doesn't make your training better if you don't do that. And then a lot of people will take a break in between their set of 5. Some people don't need a long break. see what works for you. Some people will take a minute.
Yeah, but hey, do you think, so we're going to titrate to see what your level is? Actually, that's fine. Let's do that first. Then we can show the normative data article that I sent you, Ron.
Okay.
Okay. So for us, Ron, we recommend people do a half a turn or a quarter turn, but I think you can add a full turn for your first one and still be okay. So a whole turn, the first full turn is an additional 30 centimeters of water pressure, and that'll get you up to 60.
So I'm going to go from 1 to 1.
So you're going to go
again.
1 to 1 all the way around.
Yeah. I always tell patients righty tighty, lefty loosey, kind of like with screws.
But then they'll hold it the other way around and they'll be like, that's wrong.
Oh, that's right. Oh, I guess you're right. I tell them to turn the knob right. Yeah, that's a good point.
We've had that complaint. So, and then if you try to do a rep, you're going to notice there's more pressure, right?
Easy.
Good.
I'm gonna
just to know, Ron, I've had patients that couldn't even do the 30.
Oh,
Yeah.
wow.
So, and we had to get there's another device they have that goes from 0 to 75, and we have to downgrade them to that device until they can work their way up to this.
And then, okay, so the first full turn is 30, the next full turn is 15, and then 30 because of the way the spring works. But if you are not doing research or not doing anything like that, we say you can take an average of 6 centimeters of water pressure for every quarter turn for this device, just to kind of have an idea of where you are or an estimated number. But for now, we're on 60. We're going to use the actual calibration chart, which is available on the website.
Okay.
So if you add half a turn,
we're going to keep going here on mine.
we're going to keep going until you can't go anymore.
Okay.
So,
Bring it on.
but if that
That's
was
not over. There's more to come, Ron.
crazy. If that was easy, go to 3. So add a half a turn. You added 7.5 centimeters of water pressure, so you're at about 67.5.
Jenny, can you go over that in detail? So it starts at 30. The first
30.
full turn is 30 more.
30 more. The next full turn is 15. The third full turn is 15. The final full turn is 30.
So 30, 15, 15, 30.
Yes.
People will come back to the video to watch that, because that's an important point, because it's not intuitive.
Right. That's why we say you don't necessarily have to follow it to a T like that. You can just do 6 centimeters for every quarter turn, and it'll get you to an estimated amount or number. But the calibration chart it's available on our website, EMST150.com, and all of those resources are there.
And Jenny, you can show it right up to the screen, but those colors essentially reflect 30, a little bit higher, 30, 60, 90, 120, 150. So it's on there.
Yeah.
And are you at 60 now, Jenny? You're at 45 technically.
So I added 1 full turn, and then I added another half turn. So 1 full turn got me to 60 plus 7.5 because
67.5.
Okay.
That next full turn is 15 total. Yeah. So at 67.5, if you try to do the rep, see how you feel.
This is a math class, Ron.
I know. No pressure. Easy.
Getting harder.
I appreciate your honesty.
Man, this hurts the muscles at the back of my neck.
It shouldn't hurt. It shouldn't be painful.
I have weak muscles at the back of my neck. That's like my big problem. But I can feel. You can feel the engagement, activation at the back of my neck, and it's like, giving me the heebie-jeebies a little bit.
We can work our way through that, hopefully.
But it just goes to show I'm being pushed here now.
Right, and I'll say if it is painful or uncomfortable, you're going to lower your training pressure, because you don't want to be training in a space that it is painful or uncomfortable.
I think maybe I'm just compensating a little bit. And if I just pay a little bit more attention, I can probably isolate the breathing muscles a little bit more.
Yeah, you try it. You tell us how you feel.
So we're still at 67.5.
So yes, we're still at 67.5. If we add another half turn, how does that feel to you? If you bring it back to 1, so that's going to bring us to 75.
Mm-hmm.
And I can actually see the muscles in your throat engaging.
It's amazing you can do it without closing your nose. That's,
How does it feel? You can still do it.
It's tough. Yeah,
it's
for
tough.
sure.
So if you add, let's see, we can try another half a turn. That's going to be 82.5.
No, it's 82.5.
I'm at 3 again.
You're at 3 again. Let's see if I could do it. But don't be intimidated. I've been doing this a long time. Yep. So you don't have to keep going. And then, so 82.5, let's see, what should we add? Is it very hard or kind of hard?
Kind of hard.
So if we add another half turn back to 1,
Mm-hmm.
right?
Now we're at
You're at 90.
90.
Whew, looking good, Ron.
We're 3x where we started.
Yeah.
Yeah.
And that's centimeters of water of pressure.
Yeah. So 90, like for me, that's close. That's my max. No, not yet. Almost. Yeah. But and the max will depend on the sex, on the size, the age of the person, right?
Mm-hmm.
So that will change. Okay, so 90. We're gonna, and this is now we're going to add.
So I'm going to keep going here.
Yeah, you can keep
Going until you can't pass air anymore. So let's add a quarter of a turn. Let's go to 2. And then this is
That's 197.5.
that's 7.5. 97.5 with a quarter.
Yeah.
Yeah. And that's, for me, that's my max. 97.5. Okay. Let's add another quarter turn.
Ron beats Jenny.
Don't tell my boss. Just kidding. It's to be expected. And did you add another one?
Yes, that's
No,
a
I'm
good
about
point.
to.
Men are stronger than women
Here.
here. Yes. Well, no. Well, in the normative data.
Yeah.
Be careful, doctor.
97.5. And then we're adding another quarter turn. So that's another 7.5. So we're at 98 plus 7. So we're at 105.
Okay.
And you can still do it. So if you add another quarter of a turn.
Ron has pretty good expiratory muscle strength.
Yeah.
Starting here.
What can I say, Doc? Been at this for a long time. I also play the didgeridoo once in a while.
You know, one of the studies is with a didgeridoo. I can't even say it. Didgeridoo?
Yeah, the didgeridoo. Mm-hmm.
There is a study that uses the didgeridoo.
Yeah, I think I'm saying it right. I hope I am. I couldn't spell it, but I think it's
you are.
didgeridoo.
Yeah. Wait,
Yeah, and I something I've written about before on my Substack is the work that's been done on didgeridoo for sleep apnea.
Yeah.
There's a whole
Yes.
community out there that uses didgeridoo and learns to play the didgeridoo to
Yes.
try to improve their sleep disordered breathing. And that's just mostly expiratory, but also inspiratory training. So that would be analogous to this in terms of like its effect.
Yeah.
And I've gone down that road a little bit. I have a didgeridoo and I use it once a week just for fun, mostly to scare my daughter.
This is a whole lot easier, Ron.
It is. It is.
Where are, you know what? I'm so sorry. I forgot what number we're on.
I'm 1 quarter turn away from 120.
Okay. So
If I go one more quarter, then I'm at 120.
120.
I'm
Okay.
back to 1.
So just
Okay. So let's do 120.
Okay.
No, I can't do it.
Ooh, getting there. Finding my limit.
Yeah, but 120s are really good. Okay. So if you add,
Does that count?
yeah.
yeah,
Does it?
so 120. So you're going to add another quarter. and that's 7.5, right? So 127.5.
See, now the 5 reps 5 times a day is
You'll
making
feel it.
more sense because this is hard.
Mm-hmm.
This is like like a full body exercise almost, where I have to really pay attention and I have to really engage the right stuff and
Yeah.
hit it hard. Like if I just grab this and go, it doesn't work.
Yeah.
It's like blowing into a bottle.
Mm-hmm.
So I have to really focus.
Yeah.
All right, let me give it a whirl. So this
So
is 120 plus a quarter turn.
plus a quarter turn, 127.5. It's getting harder. You can still do it, but it's getting harder.
Yeah.
Yeah.
Oh my gosh.
Gonna have pop a
And
blood
then-
vessel.
Don't, I mean, you are increasing intracranial and intrathoracic pressure. So the pressure in your brain and the pressure in your chest. So we want to be careful also. And that's why the device stops at 150, because you don't want to get too high either.
Just personal experience, because I do this also, because you eat your own anyway. But
I do it too.
I mean, my ears pop, and then I have to close my eyes because I've never blown a blood vessel in my eye, and I blew a blood vessel in my eye, and so then now I close my eyes and do it. It's pretty intense when you get up to those higher numbers.
Maybe do it lower.
Definitely.
You don't.
I want to see if it works.
Well, I think we don't recommend doing anything that might be at risk of blowing a blood vessel or anything like that.
But there is an intensity to it.
Yeah, there is an intensity, and if and then you realize why you might want to take breaks and why you might want to go slow.
Oh, that really hurts.
Okay.
It hurts like more.
You got to just your breath, though, just the breath.
Yeah, and maybe try not move. Right, you don't need to.
If you pinch your nose, does that make it easier? Because usually,
I'm gonna pass out.
Don't pass out.
yeah, you could be hypocap. Anyway,
Where's Lisa? Get Lisa Cush on this call.
yeah, but so we should keep going because we haven't reached. Remember how this works again? This is a pressure control valve, and so you have to reach the pressure to be able to open the valve, and you can still open it. So we should keep going until you cannot open it.
I don't know if I would feel comfortable going too much higher in terms of my regular practice, but I'm happy to keep going just to see if I can do it.
Sure.
But I'm more in Jenny's camp, where I would find the max, and then I would probably dial it back a little bit just so I could have better form and less pain and compensation.
And that's and you're going to increase your max as you go, right? So you don't necessarily have to. I know it is great to start at a higher number, but you can start at a lower number and get to a higher number too.
You will definitely get stronger, Ron. This will look basic to you in about 2 weeks.
Oh, really?
You're going to be maxing out the EMST.
You will be shocked how quickly you get.
No kidding.
Yeah.
Yeah. This is great.
Pretty cool to see the improvements.
So I'm at.
So you are.
I'm still at 120 plus a quarter. Should I go another quarter?
If you feel comfortable.
To 3?
If you feel comfortable doing it. Dr. Rama's like, yeah.
Well, we just go till they can't do it. Then we roll it back a quarter turn.
Yeah. This will do it. But it's hard.
Yeah, it's hard.
But I bet your met.
We don't want it to be easy, right? We want to improve. I tell people fixing sleep apnea is hard work. You have to lose weight. You have to get good oral muscle strength, respiratory muscle strength. You got to keep your sugars under control.
Please don't hurt yourself.
Well, people hurt themselves in the gym sometimes.
No, hey, I'll keep going. I'm going to go another quarter turn.
Yeah, if you go, you're maxed out, right? Are you maxed out? If you go?
Is that the end of the device?
Can you turn it anymore? Try it.
Oh, yeah, I can turn it a lot more.
Maybe we got our calculations wrong.
Mine is at the end.
Okay, well, just keep.
Okay.
If I go all the way to 1 again.
Yeah.
No, but then I can keep going past that.
Well, it's okay. Just stop there. And we don't know where you're at exactly, but just We know it ends at 150. So we'll figure out.
Check this out. This is where my thing is at. It's at the base of the red line.
Yeah.
Yeah, you're close to the end. That's probably 140, 150, somewhere in there.
All right. You want me to try it?
Yeah, try it.
Oh, that hurts.
But you can't do it, right? You weren't able to open the valve.
I think I can do it.
I bet you in like 4 weeks, you'll be able to do it for sure.
I'm not hearing it well. Is it happening?
I'm not doing it.
It's
okay.
barely.
Then you have to roll it back a quarter turn. And
So-
then that's what I would do at least. And
But Ron, how far away from the end are you? So we can just calculate, like if you go all the way to the end, how much more is that?
yeah.
Because like I'm at the end already. So I don't
How
know.
many more turns to the right do you have?
Okay, tightening it.
How many more till it stops?
Oh, there it is.
Okay, so how many quarter turns back do you go to? Did you go forward? Like 3?
Oh, probably 2 or 3. Yeah.
2 or 3. Okay, so then you were probably at like 135.
So go back one full turn maybe from the end. And then maybe,
Yeah,
and
then you'll get
roll.
to 120 about.
Okay, so I'm between 3 and 4 now. So I'm going to go.
Just go back to 3 maybe. I don't know. To the
Go back all the way.
There
yeah.
it is. That's a full turn back.
Okay,
Yeah. So is that beyond where you were last time? Let's just try it to see if you can do it.
that's about that's about 120.
So maybe one more quarter turn to the right. Yeah, and try that.
That's like 127.5.
Yeah, that's a good place for me.
Yeah.
That's hard as hell for sure.
Again, if you're feeling pain, my recommendation would be to lower it and get to a place where you can comfortably do 5 reps.
Yeah. I think this might be a good time to pull up that article I sent to you, Ron, with the normative data, and
is that MIP and MEP? Is that Rhino?
no. It's the maximum respiratory pressure reference equations for healthy adults and cutoff points for defining. It's an article. It's a PDF article. Do you see that?
Yes, I see that.
Yeah,
I do see that.
And
yep.
so, if I just had to just say that right now, why I like this article, I looked around for some normative data, and a lot of it's based on 50 people, 20 people. The sample sizes are really small. And what's nice about this article, it was released in 2023, just recently. It's a Spanish article. They took 610 people, and it presents the normative data in different ways. It grouped it, first of all, between men and women. And then it also grouped it based on age, 18 to 29, 30 to 39, 40 to 49, 50 to 59, 60 to 69, and 70 to 80. And then it also defined what it considered the lower limit of normal is that's acceptable, and what the normative and what the average was for that age group and sex. And so, so in a nutshell, it's kind of complicated, but I sent on my website, I put the same numbers down, but you can just go to those. I think I have maximum expiratory pressure. I sent a link, like another image, a screenshot, and this is all in the article, but I think I presented a little bit cleaner on my site. Do you have that image, Ron? Maximum expiratory pressure. It just says maximum.
Just the MIP and MEP.
It's a MEP.
Yep. Hang tight.
And so this is where we can kind of look to see where you're at. Now, this is all data that was presented in this, it's all Spanish, but in Spain, in multi-centers.
And I think with a lot of the normative data, though, we still have to account for it, like that it's not super diverse in the population.
I just literally took the numbers from the article. And so men are on the left, women are on the right. The lower limit of normal is on the first column is the age range, right? The first column is the age range. Maybe just put the expiratory one up because that's what we're dealing with for you right now, Ron. we'll pull the Inspiratory out later, maybe. So we select your age range, right?
30 to 39. Yep, I'm 34.
Okay. And so the according to this article, the lower limit, the 1.645 standard deviation, when they say you should treat this, is if you're below that lower limit. And the lower limit of normal is 120 centimeters of water. According to this, the men mean was 200.7. Seems a little high to me, but that's what what it got.
Whoa, time out. So, wait. So the average of men 30 to 39 in this study were at 200, and I ended at like 130.
Yeah.
So who are these guys? Are these like professional swimmers or something?
This is
Beowulf?
Yeah.
And again, I think that's the thing that we want to look at with the normative data is like, who was the population? And maybe it wasn't very diverse, and maybe it was, a little bit homogenous.
These were Spanish bullfighters.
Everybody's doing their EMSTs over there.
Wait, was this after training, or was this at the start? They were at 200.
This was just tested. This was no training involved. This was just they came in and they were tested for their MIP and MEP.
Why are men 50 to 59 the strongest?
I think they had only I can't remember how much, 10 or 15 people in each group, right? So there's going to be some variability.
This doesn't seem quite right to me. Maybe were they using EMST 150s?
No, they used the manometer. They used the micro RPM in that study. So a manometer is not a device. It is a device. It's not a respiratory training device. It's the assessment device that'll test your MEP or your MIP, your expiratory or inspiratory pressures at their max.
Right. So maybe that's explained by the fact that the way that that's measuring someone's max is different than the way we're measuring it using this thing.
Well, I'll tell you my Vitalograph. I use some Vitalograph MIP and MEP, and that's like super high end, and it actually matches the EMST 150 pretty closely.
Yeah.
So when I see them, right. But I don't know I've never used the other one because it's an older device, and the
micro RPM is similar also. You're going to get similar numbers because these devices are calibrated, but if you want an exact number, like whatever number you got here, you wouldn't refer to it as your technical MEP. You might refer to it as your training, your baseline training point or something like that, because in order to get like a MEP, you would need a device such as the Vitalograph or the micro RPM, which is an actual manometer.
That explains a lot. Yeah, I think that's how we can make sense of this, because I feel like I'm a long ways away from being able to go 200 on this thing. This thing doesn't even go to 200.
It does not, because this is a training device, so you wouldn't be training at that high of a pressure.
Yeah, you had to
reps.
Remember, if you did 25% of 200, it'd be 150.
Yeah.
So sorry, 75% of 200, it'd be 150, right? So it goes to where you need to go to.
All right.
So, but anyway, if you look across, you'll see that women, at least in the study, had lower numbers.
So this is a sexist study.
I mean, those are pretty high numbers too. Like my MEP is usually around in the 90s or hundreds, and those are higher than what I would get.
Yeah, but it was interesting. The article that you cite for normative data, Jenny, had 50 people on it.
Right. That's an older article. And that's what we always say. Like the normative data is, should be taken with a grain of salt because of the limitations. But that's what we have. Like, this is what we have right now.
I mean,
this is the largest study out there.
Yeah, it is. That's true.
So when we measure ourselves against this normative data, we're just measuring ourselves against some theoretical average that's determined by whatever sample was used in the study. It's not necessarily a healthy normative number. It's not like you take 1,000 people who have a 0 AHI and you measure their expiratory pressure and that's your norm, and that's like what we want to get everyone to, because presumably if you're that strong, you won't have any sleep disordered breathing. These are just X number of random people of all levels of health.
These are healthy subjects, and this wasn't done just specifically for sleep apnea, right? So I don't know if they took AHI into consideration. These are just normal subjects and what their maximum inspiratory and maximum expiratory pressures were.
Got it. Okay. Yeah, it's something, right?
Yeah.
But I don't know if we've really determined my max expiratory pressure that would plug into this study. I mean, we determined it based on this, but like we determined earlier, there seems to be some disconnect between determining it on this and the way these people determined it in this study, right? Are we on the same page?
Yeah. Yeah, I may have obviously a skewed population that I see, but I've only had a handful of people just, they turn it to the very end and they have no problem doing it.
Yeah.
And the majority, but I've had people who couldn't even start it at 30.
Wow.
I have seen a lot of people, and most people can't do it at 150. There are some who have done it, but the majority of people I have seen cannot.
Mm-hmm. Mm-hmm. Okay, well, yeah, so we're not going to necessarily know exactly where I fit into this picture, but although I do have a manometer, actually, that Sandra Khan sent me, but we're not going to go dig that up, but yeah, we have some information. We have relative information that I can use to measure my progress on this device.
Yeah, we know where we are, I think, and we know that when you make progress, you'll be able to see it on the device, right?
Yes, yes, and that's all that matters.
And that's progress. What really individually what matters.
Yeah. Totally.
So the for Ron, Jenny, it'll be 5 sets of 5 breaths for 5 to 7 days.
5 to 7 days, yeah. If you feel like doing it 7 days, go for it.
And then he will turn it a quarter turn to the right or whatever to the next number, Yep,
at the end of the week.
And then he'll do that for 5 to 7 days. Mm-hmm. And then he'll turn it a quarter turn. It looks like you'll have at least 4 or 5 quarter turns, correct, Ron?
Yeah, at least that many. I'm probably going to turn it back generously. I'll probably find my max and then turn it back 2 or 3 turns, just because that's my style of fitness. Is like I go low and slow.
Oh yeah.
I don't want to. If I have neck pain every time I do this, I'm just going to stop doing it. So it needs to be comfortable for me, And go ahead, doctor. I know you're not.
No. I think so, but I think the goal is, and I think Jenny can speak to this. There was in the studies they had different lengths of time. I know in their brochures and their marketing material they say 5 weeks, but there's been benefits shown at even 8 to 12 weeks. Meaning that I think for you we should do a longer trial to really make sure your fitness is optimized. Yeah. So how long would you recommend? Can you go over that, Jenny?
Sure. So we know the general protocol is 5 weeks because in studies, people have seen improvement in that amount of time. But I know some of the other studies have used 8 weeks or 12 weeks. And there was a study recently that we talked about, Dr. Rama, that looked at BDNF. That's a protein in the brain, right? So that is an indicator of like neural changes. And they saw that after they stopped training after 4 weeks, 2 weeks after that for detraining, the muscle strength was retained, but the proteins were there were less proteins being produced. So what that can indicate is that perhaps if we want to see like real neural changes in the brain, you may want to train for longer. We don't know exactly how long that would be yet. I think this is a new study and something that we are also still learning, but perhaps, as Dr. Rama said, maybe we want to consider something a little bit longer than 5 weeks if you feel comfortable, or we can do a check-in at 5 weeks and see how you're progressing.
Yeah, that sounds good. I mean, I plan on using this thing for life, to be honest.
Me and you both.
Yeah, actually, that's a good point. And Well, first of all, let's decide on a time. Maybe 8 weeks, maybe halfway between. It's just something that, because we don't want something so long that people have to anyway.
Yeah.
And then the second thing is, it's what the question comes up with a lot of patients is, okay, once I finish it for 8 weeks, what do I do then? And how do I have to maintain it, whatnot? And the reality is, Jenny,
we do have a maintenance protocol, and I'll say we have had reports from people that are very different. Some people feel like they lose strength very quickly and need to continue training 5 times a week. But in general, people can go down to training 3 times a week at that last pressure where they ended and still maintain the benefits.
Great. Yeah, my inclination is to definitely maintain, because just speaking theoretically here for a second, here I am at age 34. These muscles are in a weak state, so to speak. So obviously in my normal life, I'm not doing the things that I need to do to strengthen these muscles. Why should I think that if I go out of my way for 6 weeks to strengthen them, that they're just going to remain in a strengthened state forever after that? Presumably, I'm going to have to always go out of my way to strengthen these muscles, unless there's some mechanism that could be explained for why strengthening them once leads to some new behavior that keeps them in a strengthened state.
I think you also want to think about you're toning your muscles, right? So you want to, if you stop working on your muscles, you're going to lose the tone. And we're toning these muscles of the upper airway. We want to maintain the tone if that is helpful, which we assume it is, right? Yeah. So you can't just completely stop. You want to maintain it.
What I found amazing is that this is just 5 sets of 5 breaths, so it's easy for people to comprehend. And that's just 2 minutes, literally. You get 12 to 13 breaths a minute. That's just literally like doing 2 minutes of exercise. And it's amazing how strong you get. It's just a fascinating.
Well, the research in general, there's a lot of research behind respiratory muscle strength training and just a lot of different populations. And like I mentioned, for athletes and musicians and singers, but also for people who maybe have conditions that limit how much they are able to physically participate in their lives. And even for preventative means, like for people who are aging, this is a great thing to keep those muscles in shape, because like you mentioned, Ron, who's training their respiratory muscles, right? But everything's tied to breathing.
Yeah. Are there any, I'm sorry, go ahead, doctor.
Oh no, I'm just the last point with Ron's protocol is we're going to have Ron preferably do a watch pad tonight.
Yeah.
And then you do the 8 weeks of training and then do another watch pad. And then good or bad, we'll meet again in 8 weeks and show the results and see if there's any improvement.
And I think, every study, not every single participant is going to see the same results. So it'll be interesting to see what happens for you, Ron, and how you feel. And then, do we want to go over the Inspiratory?
Yes, absolutely.
Do you have any other questions?
Well, you have another EMST, correct, Ron? Do you have the second one?
Yes, I do. I have a second one.
Okay. Yeah. So now we're going to set up the Inspiratory training.
Okay.
So this is the Inspiratory adapter, and you can use it with the EMST device. What it does is it changes the pressure and it makes it on the inhale versus on the exhale. So with the EMST, when you're blowing into it, you're blowing against the pressure. With this one, you're going to be inhaling, and you get the pressure on the inhale.
Yeah.
Right.
And just to add some logistics, I have all my patients get 2 EMSTs and one of the Inspiratory adapters. So this way, because you're going to have different numbers, your Inspiratory strength is different than your Expiratory strength. You're going to be making quarter turns. For 8 weeks, it's worth the extra $60 to get an extra EMST.
So you don't get lost.
And I want to mention that the lower threshold device, the one that is from 0 to 75, is covered by Medicare and some other insurances. So if it is something that people bring to a healthcare provider, they may be able to access it that way.
Yeah, both of these EMST 150s are they're both 150s.
They're both 150s.
For a second, this was the lower one, but it's not.
Right. Well, the 75, the only difference is it goes from 0 to 75. So if somebody is maybe older or more impaired and may not be able to reach those pressures. They could use a 75. We thought you'd be good with the 150 run.
You have a very nice way of putting things. I would have been a little more harsh about that.
We try to be kind. So with this, you're going to adjust it the same way, but I'm just going to show you how it works before you add anything, because it's going to be probably harder. You're going to just place this onto it. That's it. And then you're ready to go.
Oh, it fits nicely.
Yes. So for this, the way we recommend doing it is to blow all of the air out into the device and just inhale.
The end of your device looks different than mine.
Oh, you probably put it in the wrong way.
No, wait.
Oh, no.
You don't have to put them out. You can take the mouthpiece off. It's not necessary.
Yeah, you don't need a second mouth.
That's what it is.
To keep it simple.
You got some extra parts. You will have extra parts when you get the second unit.
Yeah,
Nice.
we give you all the fun things. So simple. You're going to exhale all your air out and then inhale in. And you'll feel that. So blow all of the air out and then inhale.
Oh, I like that better.
Do you? Okay. So you can increase your pressure as before.
Ooh,
So we'll
every
do
time
one
you
full
want it.
turn.
Yep. Okay.
All right.
I should label this.
If you'd like to. I find it helpful. A lot of people find it helpful to just put those labels on.
So the screw, where the screw starts, where the screw is at minimum is 1, yeah?
Yeah.
Okay. Ugh, just got itchy in my ear.
It'd be nice, Jenny, if the company did make one that goes to 200.
We are working on a lot of things, but we welcome all suggestions.
Yeah. Just because, some of that normative data is there, right? And
Yeah. You're right. I will bring it to the team.
Almost call it like a pro device.
The IMST.
Everybody's going to be wanting the pro.
Okay, and then we have a line at the screw. All right, so am I going to go up to 60?
Yeah, try it. Like 60 for me is hard.
Yeah. The inhale is a whole different thing here. Okay.
Yes, it's a diaphragm.
Yeah, that diaphragm.
And external intercostals.
And you might hear, so there is a little bit of feedback. That's normal. It's just the valve gets stuck sometimes.
Patient's comment, it sounds like a duck horn or something.
Sound like a duck horn, but it was at Duke University. And you're doing it right.
But it's good to know that that's normal. So it's
That is
normal.
It was originally used at lower pressure, so they didn't see that. At higher pressures, you get that. So it means you're getting to a higher pressure and you're doing it right.
Okay.
So but you see all your neck muscles just straining. You can see the. But so when I ask my patients to do it, I say I don't like the staccato, not the staccato. I like a nice continuous.
It does sound more pleasant.
Exactly, and if you can't do it, then I roll it back. But you can roll it. You can go another turn maybe. Ron is ready to go.
On our social media for Aspire, there's a video of me under endoscopy, and you can see my upper airway when I'm doing the EMST and the IMST, but you can just see the expansion. It's really cool.
What are you seeing exactly?
So with an endoscopy, you get a view of your throat. And when you do the expiratory muscle training, you can just see like an opening.
Like the vocal cord abductors, or
so the vocal cords, the arytenoids, Dr. Rama, like the space around there opens up.
Fascinating.
And you can see the muscles tensing. Yeah,
because there's so many muscles that we can't, and this targets almost all of them.
Exactly, and like we're not really like assessing all those muscles, right? Because it's hard to do that. You can't really do that with the SEMG or something non-invasive. But they have there is a study on the genohyod, which is a muscle that also like moves the hyoid, but is involved with the tongue and swallowing and breathing. And that study was done with an ultrasound, and they looked at EMST training, and they saw that the muscle mass increased with the training, meaning that that muscle was targeted, right? And it got stronger. I'm sorry. Go ahead, Ron. So you had...
so he's at
you did another, did you do another full turn?
60 plus a half turn.
Oh, okay.
I'm going to go a full turn.
67.5 then.
I can go a full turn.
Yeah, do a full turn. Make it easy for the audience. Now 75, right?
Yep.
30, 15, 15, 30.
30, 15, 15, 30.
Okay, now I'm at 75. This is nice and tight.
Mm-hmm. You can still do it.
Yeah, it's all right.
Yeah.
Kind of jumpy.
Oh, yeah.
Try it again. No staccato.
Yeah, no pulse. We want continuous, not pulse.
Yeah, nice and smooth honking.
Luciano Pavarotti.
There we go. You look at that diaphragm. Good.
Oh, I'm cramping.
Yeah.
So I think you can keep going to 90. One full turn.
You feel it though, right?
Oh, I feel it. Yeah.
You feel it, yeah.
Okay, so why don't I go another full turn?
Did you? Yeah.
That puts me at 90.
Yeah, that's high for.
Well, we'll see what the normative data shows.
Yeah, we'll see. But for me, that's impressive.
I don't think I'm going to be able to do this.
Try it.
Okay, everyone's watching, Rod.
No pressure.
Look at those muscles.
Yeah.
Like it's really intense.
It's super intense.
Yeah.
It would be, I mean, I'm not going to do this, but I bet you if I were to take my shirt off, you could see the No, it's...
see all the way to your diaphragm.
I bet you would see some cool stuff. Because I'm actually getting cramped up right here as I do this.
Well, your diaphragm, is here. So, and then your intercostal.
But I feel it all over, Ron, when I do it.
Yeah.
Good. It requires concentration. You really have to be like pointed and focused.
Oh.
So we can go another turn, right?
You can try. You're going to max it out?
I don't think that's going to be maxed out, is it?
No, I'm at 90 now.
Okay,
so
you're at 90.
You'll go to 120 or whatever.
I'm definitely not going to be able to do 120, but I'll try it.
You
I
might
know, you're
surprise us.
coming off pretty strong.
Yeah. Almost. I would say your MIP is probably higher, but that's about where I would probably stop.
Yeah.
That's
So your actual MIP is probably a little higher than that, but functionally that's too high for you.
Yeah.
So you should turn it back a quarter turn at least.
And you might even want to turn it back. Like for IMST, we sometimes turn it back a little bit more because it is a little harder, but
that's a half turn back.
That should probably be good.
3.
Maybe.
let's see. See if you could do 5.
No, definitely not. No, I won't be able to do 5.
So then you would go wherever you.
Let's see. We're curious.
Dr. Rama's like,
I'm all ready to go.
You would be an amazing personal trainer.
yeah, right. It's like, when they're like 1, 2, 3, 4, 5 and 5 and 5.
He's like the David Goggins here.
Yeah.
Does that count? I mean, it's sloppy.
It's a little sloppy.
Yeah.
Very sloppy.
I would breathe really stop and take like a full breath in between so you don't pass out. Yeah. I'd probably go back.
You see, it's interesting. See, you actually get weaker. You notice that. That's why, yeah.
Yeah. Well, when you're going through the training,
So when I said it with my patients, I make sure that they can do at least one set in front of me, 5 good ones. Yeah. And then I say, that's your pressure to start with.
Now I'm back to 60.
Oh, you turned it a half a turn back?
I went a half a turn and then I just went another half turn.
Okay, that's fine. Okay, let's see. So do 5 of these.
I doubt it. I'm not feeling 5, but I'll try.
Mm-hmm.
And you don't have to do all. Yeah.
You take a break. Yeah.
You can take breaks as long as you need to. And sometimes we even say, like, if you're going to do EMST and IMST, you don't have to do it one after the other. You can do one in the beginning of the day, one at the end of the day, or break it up if you need to.
Very sloppy.
Oh, no, it's okay. I think that was okay.
Yeah.
Because it's amazing how quickly you get stronger. So it's okay if it's not perfect. Mm-hmm. There you go.
And I want to say, like, all of your respiratory muscles are skeletal muscles, right? So just like your biceps, a lot of people are like, we're going to train your lungs. They're going to be so strong, and your lungs are organs. That's organ tissue. You can't actually strengthen organ tissue. But all of your respiratory muscles, including your diaphragm, are skeletal muscles, and they can be strengthened.
In nature, how are these muscles strengthened? Like, is this stuff strengthened through, sprinting, or through wrestling, or through, throwing a spear and hunting animals? Like, how does nature do this by itself? I
think in nature, these are not targeted directly, but probably indirectly in a lot of the things that you do, especially like athletes, because they're so active, may have like higher MIPS and MAPS. But for a lot of people, they, like Dr. Rama said, they do have weakness. You might even be surprised who has weakness.
This is really unpleasant in a lot of ways.
Yeah.
I'm definitely going to turn it back another half turn.
Yeah. I would say, like, put it at a place where you're going to do it, right? Because if it's so uncomfortable and unpleasant, people are not going to do it.
Yeah.
So, Jenny, can I ask a question, actually? Because I'm learning about this myself a little bit, but, like skeletal muscle has those fast twitch type, fast twitch.
Fast twitches, slow twitch.
Yeah. So does this, because this is short, staccato, like reps, does it increase the fast twitch fibers?
So I don't know exactly, to be honest. But I would imagine that it would increase whatever fibers are being used in the movement, right?
Yeah. Because fast twitch, that's the quick, powerful movements, and the other ones, the slow twitch, are more of the endurance. I'm just kind of curious if this company has done any research, because I don't remember looking it up, whether it improves the fast twitch and the slow twitch. Does it improve the intensity and the endurance, or just one or the other more?
It depends on your protocol that you're training, right? Like if you're,
okay.
I would imagine, we don't actually do any of our own research. We've been very lucky that all of the research that you'll find with the devices is independent, peer-reviewed research done by other researchers. But that would be a very interesting study. Yeah. Again, I think we have had 3 ideas so far for research studies in just our short talk.
So what did you land on, Ron, with the device? Are we back at 30?
No, take it easy on me, Dr.
I don't even want to tell you where my pressure is.
I'm actually really exhausted. Like, I feel like I have
it's a workout.
Yeah.
And let me just throw another tidbit. I give a lot of stuff for my patients to do. It's a whole workout, but they enjoy doing this one for whatever reason. Compared to myofunctional therapy.
Because I have the same experience, and I think it's because it's like such a tangible thing, and you can see like what you're doing, you can hear the feedback, and you can also see like when you're improving. Like that's very satisfying to be able to turn it up, right? And
it's a little competitive. They're like they want, hey, I'm going to nail it this time. Oh, I skipped a day. I got weaker. I'm going to go back to it. It's kind of fascinating that they're motivated to do this, and your audience will see when the majority of them, if not all of them, are going to be motivated. So this is not one that they're going to just collect dust.
Where did I end up? I ended up at 60.
So, well, yeah.
I think that's
You all
a
right
good
with that,
training
Doc?
pressure. If you're okay with that,
I mean,
Dr.
you
Rama,
can turn it up a little quicker, Ron, if you feel like, you can handle more, because typically what we do is we go to the max and we turn it back a quarter turn or half turn, somewhere around there, right? And your max was up at, I can't remember what it was now for the Inspiratory.
127, I think.
120-ish. So
that, yeah.
typically we would have gone back to like 100 or something, right? So, but it's up to you. If it's uncomfortable, start there and you can quickly move up. So Jenny, are there any, obviously we're going to do inspiration and expiration. So 5 sets of 5 breaths of each. So 25 breaths of each. Mm-hmm. Are there any rules that they shouldn't do? Is it wrong for them to do 5 inhales and then 5 exhales and then 5 inhales? Is there anything for the audience that they should not do? You can do it at different times of the day. That's not a problem. You can probably do it in succession. That's probably not a problem, but can they mix it up?
So there's nothing to say that you can't do that, right? But we don't have any research supporting that you should do that. And I think that probably mixing it up would be pretty tough, going back and forth. Yeah. So I think we know that it's effective to do one and then do the other. And we would recommend sticking to that. If anybody else wants to try something different, there's no hard no to that.
So you would do Inspiratory, take a break, and then do Expiratory?
Yeah, or I would even do one in the morning and one in the evening, depending on how you feel, right? Because you might do your 5 sets of 5 and you might be really tired.
Does doing this stuff change the way the body looks at all? Does it make the neck more defined, or does it contribute to a 6-pack or anything?
It could.
Summer body. I wish we could advertise that. Not that we know. It does engage your abdominals, we know.
I can tell because I'm feeling my core on fire.
You will. Yeah, absolutely. You'll feel it in your core. Yeah. So I think it also will help in any other physical activities that you participate in, right? Because we know that from research. It can training your respiratory muscles and having stronger respiratory muscles can attenuate the metabolic reflex for athletes. That's important because what happens is when the metabolic reflex kicks in, the oxygen gets pulled from the limb muscles to the respiratory muscles because breathing is going to be the priority, right? And so in order to prolong before that happens, or to give athletes a little bit more endurance, they have found that doing the respiratory muscle training and having more efficient work with the respiratory muscles can help with that.
And just on a clinical level, a question I had is it better to do it at night, especially the expiratory, because it supposedly reduces AHI versus, inspiratory? But then if you do it at night, are you fatiguing the muscles versus strengthening them? It's a lot of that. I actually think timing there's probably some importance in timing, but I haven't sorted it out yet.
So for us, we generally recommend doing it the IMST before bed, because in the studies, it was typically done at that time. We don't know that it wouldn't be effective at another time, but we do know that it was effective when it was done shortly before bed. And actually the co-founder of the device, the co-inventor, Dr. Davenport, he does this every night before bed, and he swears this is the reason why he doesn't need, why his sleep apnea is better controlled.
Yeah. I'll say one thing. This is just my personal experience with the device. When I do at least the expiratory, for instance, if I do it in the morning, it's easy. Yeah. When I do it before I go to bed, it's harder, probably because I'm more fatigued from just being up. I'm guessing is why. I don't know if that's the case for all people.
Perhaps, but then you want to, if your muscles are toned, right? You're toning your muscles right before bed. Perhaps they can retain that tone in the evening and help maintain that patency a little bit better. That's not something we know for sure, but something that perhaps might be true.
What is muscle tonality? Is that different than strength? Because you're saying that is tone bringing it online and priming it? filling it with blood, something like that?
I'm not sure.
That's how are we defining tone? I would think like reduced fat. I mean, I had to look that up. I had to look up the actual medical definition of tone.
But toning is not necessarily like a.
So I think it's the
Doesn't
tension,
mean it doesn't
right?
mean warmed up.
I wouldn't say warmed up. I would say how tense it is, right? When your muscles tone to tense, right? So if your muscles are tense, they're not flaccid. They're not right. And and Dr. Rama, you can probably speak to this better. Part of the issue with OSA is the muscles, right, collapse, or the airway collapses.
Yeah. Well, I know, like in myofunctional therapy, we talk about good muscle tone of the tongue, and at least what that means usually is just having your tongue resting at the roof of your mouth in an active position versus just
being active,
versus
right?
just sitting there like a limp fish or something, right? So I think maybe tone is just a small sense of just being in an active position or active state.
Right. Probably the amount of tension in the muscle, even in the relaxed state, your muscle will retain some tension. And if it's more toned, perhaps it'll retain more.
Yes, you're right. But muscles always have some tone.
Right.
So maybe it just means your baseline tone is high. Your baseline relaxation is less relaxed, maybe.
And that really does make sense, because less tone, right? The less maybe.
You come up with good questions, Ron. I don't know. Sure. So let's pull up the Inspiratory data, if you don't mind.
I got
From
it.
the article. I summarized it because the way they presented the article is a little confusing. I just summarized in a chart and
those articles are
and so we know Ron was around 120.
127, probably 130, and
probably 130 probably. But he landed on, that 60 to 90 range for, comfort at least, but for the maximum.
But I agree that the Inspiratory is more uncomfortable to do.
So Ron, according to the data, see, you question the data, but yet you were spot on for Inspiratory. You were spot on at 130.
Yeah, but I don't consider myself an average guy, Doc.
Isn't that so interesting though? Like you're spot on for Inspiratory, but for Expiratory, you weren't exactly at that range.
Maybe that's because I've been a smoker in my life, and I've done a lot of
You've activated your diaphragm a lot.
No, I'm not even joking. That's
interesting.
Honestly. And I was going to ask, do smokers score better with this stuff, or do they score worse? Because I would say I'm not sure about that, because they probably have a lot of neurological training of the inspiratory muscles, even though there might actually be damage to the lungs from the smoke, if that makes sense. Like, I feel like a lot of what I'm channeling when I do this is like my former blunt smoking self, if that makes sense.
That's interesting.
My words, not yours.
Yeah. Well, generally smoking is bad for the lungs, so I'm assuming it would make it worse.
Although Michael Phelps is a smoker.
Is that right?
Pot smoker, yeah.
And I don't know that we have any data
so
that I'm aware of.
So regarding your protocol, Ron, like with the Expiratory, we're going to keep turning it a quarter turn until you basically max out on the device, which will be 150.
Okay.
But on the Inspiratory, Jenny, what's your recommendation? I'm curious, because according to this, the mean is 130. Should Ron just keep turning it a quarter turn to 130, or just keep going until it's completed? And you will get there, Ron.
Yeah.
And take you above the mean for inspiration.
My recommendation is to do it if it feels comfortable, right? But if it, like, you were getting really uncomfortable and painful, if it feels like that, I would say stay where you are and increase it as you can, right?
Yeah.
You don't necessarily need to max it out, but you can improve that strength and be above the average. People.
I'm definitely not in a hurry to like go super high with my maxes. Like, just as a reference point, with my other fitness training, like with my kettlebell training, with Turkish get-ups, for example, I hit a certain point, let's call it like 20 kilograms for like a bottoms-up Turkish get-up, and I just have maintained that for the last 2 years. Like, I'm not trying to like go up from 20 kilograms to 22 to 24, because when does it end? Like, at some point, I just like to do what's comfortable and what's maintaining my body at a healthy place. And so I'm definitely not a person that has a mindset of like, oh, I gotta keep going and gotta. That being said, with these muscles, there's a real functional benefit to pushing. And since I really don't trust normative stuff anyway, because who's to say that this normative data indicates any really worthwhile health threshold that's worth achieving. Like, my inclination would be to keep going with this stuff, but at like a slow, steady pace that was not exacerbating my neck stuff. Because definitely, I can say for sure, my neck is feeling a little tense right now, and it's almost like I have a little headache forming. And that's kind of my issue. Like, my audience will know that, Jenny. You don't know anything about that, but the whole thing with me and how this channel started was that I have this weird muscular neck issue that's kind of related to my jaw structure and my breathing. And when I exert too hard, I get a really bad tension and pain in the back of my neck that can like turn into a headache episode. So I am definitely going to be backing off to a point where I have enough control that those muscles are not getting agitated when I do this stuff.
And we said it can be different for everyone, and that's okay. You can get these trainers online. Anyone can order them, but a lot of times people will call in and will say, hey, why don't you take it to like your doctor or a healthcare professional so they can help individualize the training a little bit more for you, because maybe the general protocol is not for you. And that's okay. It's a general protocol for a reason. It's a place to start, but it's something that can be adapted based on tolerance for everyone.
And Ron, you've probably done about 100 of them already today. I'm just saying, like, you've done more than like you should have. Does that make sense? And in a relatively short time.
Yeah.
Hey, Jenny, just curious, what was your lower limit? What was your threshold for the Inspiratory?
For Inspiratory, I didn't do it all the way today. I think I stopped at 60, but let's see.
Because I'm just wondering how you fall in line with this.
So that's 60.
So
I don't know if I can do, okay, let's do 75. I see, like 75 is.
But you can do it. You can open the valve.
Yeah.
So you're higher than 75.
Yeah, I can do it. Let's see.
Maybe 82.5 or something.
That's maybe.
Yeah. Have you ever done a sleep study, Jenny? Do you know what your sleep is like?
I haven't, but you know what? I've been reading all about sleep apnea, and basically most people don't even know they have it. So now I'm always conscious of it. I'm thinking about it. I can be another test subject. But I do the EMST before bed. And anecdotally, people have said that it improves things like snoring, and the amount of times that they wake up at night.
Well,
and
you don't snore, though, do you?
I don't think so, but occasionally.
Just wondering.
So what number were you, Jenny, then? You were 80 or so, or 75? Or? So you got 80.
That's 82.
So, okay, let's keep going. Because, I want to show that the normative data numbers I use are decent.
This is 90. 90. I can still do it.
So if she can make any sound, that means she's able to open the valve. Versus the continuous stream devices, you can cheat.
Impressing myself. That was.
So you're close to maybe 100, 95 maybe?
Yeah.
So let's look at the data again, Ron. I'm just curious where Jenny would lie on the Expiratory and how. Where would you? Which row are you?
40.
40. Okay, got it. So 60. Oh, so yeah, you're the mean. Perfect. Ron, this is.
Yeah. Hey, this it's good data, Doc, for sure.
So,
okay, we turned that corner.
the Inspiratory is really on point for us.
The Expiratory, I think, was way out in left field, but something about the Inspiratory is.
Mine was pretty accurate. But
Hey, so So clinically, I insist on one subset of patients use it. Whenever we always start CPAP right in the office on patients just to try. And there's some patients that when you put it on, they have an incredible difficulty exhaling against the air, even at 4 centimeters of water of pressure. In fact, sometimes I had to put them on a fixed BiPAP S mode at 4/3, where they breathe against 3 instead of breathing against a pressure of 4. So 4 inhale and 3 on exhale. But I think a device like this should almost be standard in a patient, because you can put 10 people on CPAP. 2 or 3 of them will say, whoa, I have a really hard time breathing against this air. And those patients likely have low expiratory respiratory muscle strength. And so it would be a nice way to get them to acclimate to CPAP better.
The BiPAP, doctor, just so I can understand, does that reduce the resistance against the exhalation?
Yeah. Well, yes, exactly. You said it, where the inhale is higher and the exhale is lower. But the minimum pressure that a device delivers is 4 centimeters of water. Like CPAP starts at 4 and goes to 20. A BiPAP starts at 4 usually and goes to 25 sometimes, right? And some of the other devices can go to 30, whatever. But what the interesting thing is, when you use at least the ResMed device, the BiPAP S mode, which is a fixed mode, I can actually drop the EPAP, which is the pressure you breathe against, to 3. And so for my patients that are super sensitive to not being able to tolerate a CPAP even at 4, I put them on a BiPAP with 4 being blown in on inspiration, and they breathe against 3. Anyway, the point I'm bringing this up is not to bring that up, which is interesting, I guess, but is to show that sometimes these devices can accelerate their acclimation to CPAP or BiPAP versus saying, hey, just wear while you're awake for 30 minutes for like sometimes a month before they get used to this 4. They can accelerate it by just doing some training.
Yeah. And I think even separate from sleep apnea, it's like such a whole person kind of intervention. There's data showing improvement in cardiovascular things like blood pressure and such. So for a lot of people, as long as you're conscious of the precautions or contraindications, it can have very whole person benefits aside from the sleep apnea.
And then I have a little bit of a show and tell. I sent you 2 more images. One was a pre-rhino, and if you can pull that image up. And so I had one patient. I've only had one patient so far that, we got a rhino manometry on her, right? And we're going to show that and then she did nothing. She did not do CPAP or BiPAP, surgery, allergy treatments, nothing. The only thing she did was EMST and IMST training. That's it. Nothing else. So I got a rhino on her before. And do you see it, Ron, the pre-rhino?
Yes.
I think I wrote pre or something on it, right?
This is so interesting. I have not seen this before.
And I just want to make a few comments on the rhino. Show just the pre. Just show the pre.
The pre is on the left.
Okay. So the pre, just so we know how to read a rhino, it makes an X. The top right and top left quadrant are the right nostril. The top left and the bottom right quadrant are the left nostril. Together they make an X. And the more vertical that X is, the lower your nasal resistance and the better your nasal flow. And the more horizontal the X is, the worse your nasal resistance and the worse your nasal flow is as well, right? So you can see that she was very flat, right? Her X, her very horizontal X. And if I had to go further, I'd say the light green, you want to see where the line crosses. So if that X crosses in the light green, kind of like the lime green, that's super normal. When it crosses in the dark green, it's not ideal, right? Whatever. And then if it crosses in the orange, it's like caution. It's like, and then when it crosses in the red, it's dangerous, right? It's not good. That means your resistance is high and your flow is low. And so you can see that she basically crosses in the red doesn't matter if it's right nose, inhale, exhale, left nose, inhale, exhale, whatever. It crosses in the red, right? And then if you go below, so in cubic centimeters per second, that's the flow. If you look at the mean flow, the row with mean flow, Ron, mean flow, you can see that inspiration left nose is 56.6, expiration left nose is 57. So, she's about 50 cc's. What do I like to see? Oh my gosh, if you're perfect, I'd love to see 500. But I'll even take 200-300 at a minimum. Does that make sense? But the higher, the better. But and then inspiration and expiration in her right nose was 27 and 25. Do you see that? And so it's even worse, right? And she's miserable. I mean, she was miserable. And she scored very low on her MIP and MEP. And so then I said, hey, you know what? Why don't you just do this training, right? Just here. I gave it to her and she went nuts with it. She loved it. She couldn't, I don't know what it was, but she said she became addicted to it and she was just doing it all the time. She has a small baby and she just does it all day long and whatever. And I said, hey, go for it, right? I said, and then she came back and follow up and we repeated the rhinomanometer. Right?
Amazing.
But let me back up also. Let me back up to the first one again. But I tell patients there's 5 reasons why your nasal resistance and flow could be suboptimal. Number 1, you're just massively inflamed. Like, your nose is just full of allergy. The turbinates are just hypertrophied. You're like stuff like a Thanksgiving turkey. Number 2, you have an anatomic abnormality beyond inflammation, like a deviation or some type of anatomic problem in the nose that's blocking. Number 3, like nasal valve collapse, things like that. Number 3, the entire bone is too small, as you're well aware, Ron. A transverse maxillary deficiency. Number 4, if you're severely retrognathic and you have a very small pharyngeal airway in the back, you will have less flow through the nose, right? Because you're impacted back here. But I always tell patients, hey, the 5th reason is that you may be weak. And so, you may just have weak respiratory muscles. And so we're all out there, like I've done pre and post expansion rhinos, and I can clearly show an improvement. And so a lot of people are running out there trying to improve their flow with jaw advancement, maxillary expansion, nasal surgeries, whatever, right? But the point is, you're going to look at this woman here now to the right, just based on, she did more than 25 breaths a day. She just, she loved this thing, right? And so she did a lot of it. But some of the numbers came to 0 because I didn't have it set at the correct numbers. But the point is, the numbers that came through, you can see that the 57 went to 178 cubic centimeters per second. Triple. She basically over tripled her flow and just based on training her lung muscles, nothing else, no CPAP, no jaw expansion, no jaw advancement. So this is low-hanging fruit, in my opinion. And it seems like the proverbial no-brainer, to try it.
Yeah, amen. I mean, this data speaks for itself.
Yeah.
Hey, it's
still abnormal, but it's
right, because she was going to cross in the
we wanted her to cross in the light green.
Right, we wanted her to cross up here.
Yeah.
This is an incredible visual, though.
Yeah.
And to my earlier point about nasal breathing and how this is a mouth breathing device, well, clearly there is a lot of overlap between whatever this does and nasal breathing, because the data that we're looking at here, which is rhinomanometry data, is measuring nasal flow.
Yes, exactly. So I was just wanted to share that nugget with you. I thought it was...
Well, after that, now all we need to do is negotiate my my commission on each one of these devices that's sold.
That's exactly. I have no part of the company. Zero, nada for me. So I
don't work on commission either. I just do education.
All right. Sure.
This Dr. Davenport or whoever this guy is going to.
Well, it's honestly such a simple intervention. Like we said, low risk, non-invasive, that if it can help people, great. Like that's why I'm here, because I emailed the owner and said, more people need to know about this. Can I put the research out there a little bit more?
And this is something that people can buy through your website?
Yep. It's EMST150.com and the devices are available there.
And by that time, we'll have negotiated an affiliate link for me. So everyone, please use the affiliate link in the description of the video. Help out your boy Ron with a small, commission there.
You deserve it.
Wow. Okay. So, and this is something that people can attempt without medical oversight?
All of the instructions are on the website. We have training videos, all this stuff. And like I said, it's relatively low risk. There is a list of precautions and contraindications. And if anybody is worried about anything, then they should definitely consult with a
Jenny, can you go over any absolute contraindications or precautions? Just so I'm not sure people are really going to go to the website and look up. They're just going to start blowing and sucking, and I don't know.
All right. So, ruptured eardrum, all right, because you're creating that pressure. Pregnancy, because we have no data saying that it's safe in pregnancy. Okay. So people who have uncontrolled reflux or hypertension. Not everybody who has reflux or hypertension. If it's controlled and you're able to manage it, that is okay. And these devices, like I said, medically, I work at a long-term acute care hospital. So I work with very medically complex patients. I mean, like post-lung transplant, trach and vent. And so a lot of those people are able to train with these devices, but in those cases, the protocol has to be adapted. Right. So if there is any medical concern, you just want to make sure that you get clearance from your doctor. And if anybody needs like a medical description of devices or anything like that, any more information, they can reach out to me. My email is Jenny, JENNY at EMST150.com. I'm very happy to help anybody if they need it.
Dr. Rama, do you sell these things through your website?
No, I don't sell anything. It's zero, not through my website.
Just care.
But I do have the articles and the normative data on my website, so people can go look without having to like fish through that article. Hey, but on that normative data, Jenny, just one point. I noticed that like once they get to 70 or 80, because you work in this acute term hospital, once they get to age 70 or 80, the numbers just plummet.
They do.
I've always thought that it's important, like it's more important to have respiratory, like, I'm not sure what the word I'm looking for is, but like abilities.
Yeah. Because think about all the respiratory illnesses and then people are, if they're, and just an active lifestyle, right? Activity and physical activity is so important for so many reasons, and people are limited because they can't participate.
I mean, there's no physiologic reason why someone 70 to 80, someone somehow falls off a cliff in their skeletal muscle strength.
Well, muscle weakness, like muscles atrophy and muscles weaken with age, right? So people who are older, if they don't maintain their muscle strength or work on it, can be weak. And there's often a lot of weakness that we see. So we even say, like, for the aging population, like, this is a great, really easy thing that you could be doing. But it will help you then participate in your life, right? You can run around with your grandkids and you can do other things that are active without feeling so limited.
No, but what struck me in those charts was that more or less it was pretty similar between the age groups, kind of up and down. But then you just really declined in that last decade of whatever that they tested, 70 to 80. And I'm not sure if that was, like, in other words, that didn't seem like it should be the case. But I
mean, I don't know. I mean, people in general probably are a lot less active when they're older, right? And there are probably a lot of other things that may be going on that can limit them.
Yeah.
So,
little anecdote. I used to volunteer at a hospice house, and one thing I noticed was that everyone, when they were dying, like in their last day, they would kind of lose consciousness, and then their mouth would fall open, and then they would all kind of breathe really faintly through their mouth, to the point where one of the things that you do to comfort them is you wet their lips for them. And I remember I made a goal for myself, like, I want to be nose breathing in that moment when it's my turn. I don't want my mouth to fall open, because it's just
That will be the final episode, Ron.
But I know
everyone will watch. Every subscriber will log on and watch that.
live stream from the hospice house for Ron. No, God forbid, maybe a long time from now. But
we're just going to see you maxing out the EMST 150 for now.
So,
okay.
So Ron, I was thinking that we could reconnect, and then in 8 weeks, like, you do the watch pat, and then we can go over your experience, and,
Are you good
and
with
how
8
you
weeks?
feel subjectively.
Yeah, so the thing about that is 8 weeks from now, I will be in the heart of my seasonal job. And so I'm not going to be able to do an interview. So I could either delay and then start so that 8 weeks comes when I'm done, or we can just stretch it out to like 12 weeks. But I don't think you like that idea as much.
I don't mind 12 weeks either. But I was thought maybe too long for you.
I plan on doing this for a long time to come. I mean, I'm a believer. I mean, just from what I'm feeling, it's like this is something that's been missing for me for sure.
Just the pre and post watch pat that we're going to be doing. I just want to make sure that nothing else changes. Or this isn't a study, but still, like, you're not going to do a surgery or do an allergy treatment or do something else in those 8 to 12 weeks.
I can't do a double jaw surgery during the fall.
Let me give the people the real numbers.
Well, the only other thing that I'll be doing is a 10 TAD FME with a 10 millimeter expansion.
Oh, you are going to be doing
I'm kidding.
Oh, okay.
Jenny's like, what the hell are they talking about?
I was going to wait.
You knew, Jenny.
So we can stretch it out to 12 weeks.
I'm fine with whatever works for you.
I can meet again for another call like this at the end of April.
So you decide if you want to do 8 or 12 weeks. We'll just meet when you're done.
Yeah.
Okay. Yeah, it's January 18th today. Maybe I will. Maybe I'll start on February 1st, and then we'll meet on May 1st.
No. I think March 1st, Ron, and then we'll meet on May 1st or something.
Okay. That's too long. February 1st is too long.
Oh, February 1st to May. Oh, no, it's fine. That's 3 months then, right?
Because I'd rather start soon. I mean,
April, May, June. Okay, yeah, it's fine. Let's do 3 months.
12 weeks. Okay.
And then that'll give.
that's
And just to let the audience know, there's a lot of night to night variability in people's sleep. So if we don't see a better watch pad, it doesn't necessarily mean it didn't work. But we'll find out. Whatever it shows, it shows.
Yeah.
And you'll tell us how you feel, because, even if that test doesn't come out significantly different, you might be feeling things that it doesn't show.
I'm very sensitive. So any changes that are going to occur, I'm going to notice. I also exercise every day. I go for a short jog every day and lift weights a couple times a week. So I will notice if things are changing in the body.
Mm-hmm. Very cool.
All right.
I'm looking forward to the follow-up.
All right, fantastic. Well, this was very insightful, and I'm excited to get started on my trial with the EMST 150 Inspiratory and Expiratory Muscle Training. And hopefully, maybe I can dodge the knife of the jaw surgeon if this goes really well.
Oh, yeah. That'd be amazing.
That would be.
Ron, have you ever had 2 people on? I haven't watched every one of your episodes. Have you ever had 2 people on at once?
My second ever podcast was with Dr. Ting and a jaw surgeon named Dr. Vaughn.
Oh, so you have done it before?
I've done it twice before.
Yeah.
So, but this is a pretty rare thing, and it's nice.
Yes.
This was a very enjoyable experience. I learned a ton. I'm sure the audience is going to learn a lot too.
Please use Jenny's picture for the thing, not my picture.
All right.
You might get more hits.
Sleep apnea superheroes.
Actually, one thing that I've been doing is I've been doing better thumbnails. So if you could both email me a nice headshot so that we can use it in the thumbnail, something taken like with good definition, then I'll do that.
Awesome. Okay.
All right.
Feel free to reach out to me if you need anything. I'm happy to answer any questions or send you any research, anything like that.
All right. I really appreciate that. All right, folks. Jenny and Dr. Rama, thank you so much, and enjoy the rest of your weekend.
Thanks.